So in non-squamous non-small cell lung cancer, we typically will do a genetic profile panel. Now, at our institution, we do get a full panel for the genetic mutations, but it is generally recommended that you cover EGFR mutation, ALK translocation, and I would argue PD-L1 immunohistochemistry. For some of the other mutations, I do recommend looking for our BRAF mutation, V600E, ROS1. We also like to do the MET skip, exon 14 skip mutation as well, because we do have FDA-approved agents for other tumor types that can be used for these patients and to help treat their cancer. In addition, RET mutations can also be treated off protocol or on a clinical study. So I think it's very important to look for all of these mutations in our patients.
In my practice, which is in Northern California, I have a very high percentage of patients that have actionable driver mutations. And so we are testing all of our patients at the point of diagnosis. Just today, I'm waiting until a few days from now before I'll be able to know what to treat a patient who was just diagnosed this week. So I think it's really critical that we think about testing at the point of diagnosis for all of our patients with advanced stage disease, and then also retesting for patients either who weren't found to have a driver mutation or who have a driver mutation and have then developed resistance. So it's important to retest, especially in that setting.
What's new and what's coming in terms of biomarkers in cancer therapy and cancer diagnostics, I think that it was sort of a twofold answer to that. One is that there's a tremendous amount of information that's currently available through biomarkers. In fact, there's probably too much information, and now we're in that phase of trying to sift through and sort out what's important and what's not important. So for example, the whole PD-L1 testing right now is pretty much an alphabet soup of testing, because there's at least four different drugs. There's 4 different antibodies associated with each of those drugs. The clones for those antibodies are different. Some require that they be done on specific testing platforms. And so there's an attempt underway to try and evaluate and compare and contrast these different antibodies to see if some have a better sensitivity than others. And I think those are still ongoing. There's some preliminary data, but I think there's still ongoing data that needs to be done. So I think we've got a lot of information now, and much of it is trying to distill that information, combine it with molecular testing results and other modalities to try and then figure out the best options for the patient. In terms of oncoming or up-and-coming biomarkers, well, certainly much of the biomarker investigation has been directed toward adenocarcinomas. And I think now there's some very interesting work that's being done to look to see if there's particular biomarkers for squamous cell carcinomas. And it looks as though there's some encouraging data with regard to the fibroblastic growth factor receptors, the P10s, the PIK3 gene alterations. So I think that's, again, quite preliminary, but I think that hopefully in time that the squamous cell therapeutics will catch up with all the different options that we currently have available for adenocarcinomas. That said, we've already have PD-L1 in place for squamous cell carcinomas, but I think some of these other novel things are up and coming.